I think that we should move on to the second session. I would like to thank Caroline Williams, one of our Brompton patients, for chairing this session. Unfortunately, Dr. Peter George cannot be present in the presentation and discussion, but I will take that lead. Leo, should we play Caroline's video first?
Yes, let's play Caroline's video, please, Bergen.
So, hello everybody. My name is Caroline Williams, and I've been asked to pre-record this to explain a bit about my journey with sarcoidosis. I think it started really in 2016, I would say. I was feeling extremely tired and very anxious. I was at work and I had started a new job maybe a year before that, and they were planning in basically stopping our job and relocating us somewhere else. And I don't know if it was the stress of that or what have you, but I was feeling really, really anxious and very just overwhelmed by the whole thing. So I work for the NHS as a clinical support worker. So anyway, I get this feeling, maybe it was just the stress with all that. I just felt really, really unwell. So I went to the GP and I said, look, I'm really feeling very anxious and, you know, I couldn't make decisions. I was just all over the place. Anyway, they did some tests and they came up with the fact that I had hyperthyroidism. And then what was happening to me was that during the day, I was very weak and tired. But at nighttime, around about 6 o'clock going, I would have this kind of fever that would, I'll just be really, really hot on the outside, but very cold in the inside. And this was every single night. I couldn't work out what was going on. So I'd lost my appetite. I was losing weight. I just had no energy whatsoever. Also, what I found was that when I was drinking, I would have a glass of water, and within, I don't know, 10, 15 minutes, I had to go and empty out. This went on for ages. Anyway, I'd taken 2 weeks off of work and I was still not getting better. So I thought, you know what, I'll just go back because I don't know what's going on. And I had given up on the GP because they were just fobbing me off. So anyway, before I went, the night before I went, what was happening was that, and I was really dehydrated. I knew I was, because I was drinking, but I was dehydrating. I didn't quite know what was going on. So I went to go and put on lip balm. So I literally lived on drinking water and putting lip balm on. I went to put lip balm on and I couldn't put my two lips together. So I called my daughter and I said, Shania, look, come and look at this. Is it me or whatever? But I'm trying to put my lip balm on, but my lips feels like it's twisting. She goes, yeah, Mom, you know, you're not able to do it. Anyway, again, I didn't think anything of it. So I went to work on a Monday morning and they said, no, you can't be at work. You need to go and see the GP. So I explained again, not going to the GP because they're not listening. I've told them, blah, blah, blah. So she calls the GP, the band 7, and says, look, this staff nurse, and explains everything. And the GP says, well, why are you calling me? Take her to A&E. So I said, okay, I'll drive myself. But they said, no, you can't drive yourself. We'll take you. And I'm so glad she did, because if I'd gone there, there's no way I could have explained it the way she explained it. So I ended up staying there for 10 days while they took blood every single day, because they couldn't work out why I was having temperatures at night, but during the day I was fine. So because I'm African as well, they thought maybe I had TB. And I said, well, I've been in the country since I was 10. I've had all the inoculations that I need to do, you know, so I can't see why I'd have TB, you know. So they were trying to eliminate everything, and they thought then I had lupus, and it wasn't that. So after the 10 days, they came up with this sarcoid, and I thought, sarcoid, what on earth is that? What is it? I've never heard it in my life, what this sarcoid was. And so that was the journey from, you know, from work, home, to being diagnosed with this sarcoid thing. And to be honest, not a lot was explained to me. I have to be honest, they didn't really explain to me what it was. They just said, this is your medication, take it at this time, blah, blah, blah. And then you're going to have to come in as outpatients to be seen for your kidneys. All I knew was that my kidneys was affected, and my lungs was affected. So basically, with the Brompton now, and you know, just trying to, they're obviously looking after me. They've done some increases on my medications and what have you, just to see how I'm going to do. I'm under Dr. Karanas, Dr. Karanas' team. At the moment, we're just trying to work out how I can live a relatively normal life, because it's really interrupting my life and I'm not having a good quality of life. I then got diagnosed that I had fibrosis in the heart, which I didn't know of. But talking to Dr. Karanas, he's saying that it looks like it's an old scarring in my heart, which I'm just so baffled as to why nobody picked that one up. But anyway, he says that is what I've got. I've been experiencing palpitations at work, which 2 of them took me to A&E. So at the moment where I am is that we're working on the medication that I've got at the moment, and a possibility of getting another drug and see how it works. But that is where I am at the moment.
Thank you so much for listening. I'm looking forward to seeing you all on the event, and I'm looking forward to asking all the questions that everybody wanted to know. So see you then.
Thank you, Caroline. I noticed that you changed your clothes actually at the end.
Oh, you're very smart, aren't you? It was at take 2.
That's good though. That's good though.
Right.
Let me share my screen.
Okay.
I've been asked to cover this topic, although it is quite challenging to answer the non-pharmacological treatment options for systemic sarcoidosis. I will start by explaining why do we need these kind of treatments, and secondly, try to give some advice with regards to individual symptoms. Now, what we know about sarcoidosis is that this is a condition that presents with a wide range of either organ-specific or non-organ specific manifestations. And obviously, if someone has severe breathlessness and cough, lungs are considered to be involved, and the respiratory physicians are focusing on that. But someone who is describing fatigue, depression, or reduced exercise tolerance, or even some of the symptoms that you mentioned, Caroline, things could be quite more difficult to tease out. Now, what we know is that sarcoidosis is associated with a significant variability in outcome, and that plays a role in our decision-making about treatment. About 60% of the patients will have remission either spontaneously or even after treatment within 10 years from diagnosis. That's a given. However, it's up to half or 40% of the patients that will develop a chronic and progressive disease that would most likely require treatment, immunosuppressive treatment. Now, what we know is that the overall mortality is quite low. This is 5 to 8%. But what we have seen is that this is exclusively in patients with major organ involvement, suggesting fibrotic lung disease, cardiac or neurosarcoidosis, which is what the doctors in tertiary centers are primarily focusing on. If you expect that around a third of the patients will have major organ involvement, you understand that the reduced life expectancy in the major organ involvement population is about 20 to 25%. So although in a general population, the mortality from sarcoidosis can be neglected, in the major organ group, you can see that this is significantly higher. Now, the sarcoidosis burden is quite extensive, and as you and other patients reported, I think that we have to realize that a lot of patients are symptomatic, and that can have a significant impact in their quality of life, but also in their social and financial aspect. the symptoms can lead to social isolation and inability to work. There was a published Swedish National Registry for patients who were 25 to 60 years old that showed that patients had 8% lower income and 26 lost work days in the year of the diagnosis compared to matched controls. And that cannot really be captured or shown in many ways. In a US registry, 44% of responders showed a large effect on their household finances, and 31% had to quit their job after the disease diagnosis. And that, I think, shows the impact of the disease. Now, a lot of the sarcoidosis patients will have an impaired quality of life compared to their healthy population. And we know that some of the symptoms are predictive of quality of life impairment. This would include psychological aspects such as depression and anxiety, fatigue, reduced exercise capacity, small fiber neuropathy related symptoms, breathlessness, pain, and arthralgia. The medications as well can lead to debilitating side effects and affect the quality of life. Steroids can cause weight gain, diabetes and hypertension, osteoporosis, but also psychological problems. And we shouldn't really forget that medications can lead to events such as hospitalization for a significant amount of patients, especially in the COVID era, where we saw many patients being hospitalized with pneumonitis due to their suppressed immune system. We have been following Athol's approach with regards to treatment. So we are basically trying to closely understand as to whether the patients are at risk from their condition, whether there is a higher risk of mortality or disability, or whether there is an unacceptable loss of quality of life. And at this point, I would like to mention that these two things, the danger from the disease and the quality of life loss, they are not synonymous. So you will see many patients who have cardiac involvement that actually have no particular symptoms, and others that have no significant pulmonary or cardiac involvement that actually have a significant quality of life loss. However, it is important to note that the doctors feel responsible, and they are, in treating patients who are at danger from their disease and trying to prevent further worsening or even, as I mentioned before, life expectancy reduction, whereas it is in the patient's decision to discuss about treatment of quality of life impairment. In both case scenario, both from danger and unacceptable loss of quality of life, the decision-making should be shared. It should be a discussion where both parts, doctors and patients, try to understand where each one is coming from and try to find the treatment that best suits the patient's preferences. Now, currently, the pharmacological therapy of sarcoidosis is basically immunosuppressive regime. And this is in directing and reducing the granulomatous inflammation. Dr. Ranjoni mentioned a few things about the pharmacological interventions. And I would like to just point out that none of these interventions are curative. It is important to remember that a significant group of patients will continue to have symptoms despite therapy. So that's why it is very important to have a multidisciplinary, comprehensive approach in understanding the indications for treatment as well as the patient's preferences and outcomes. I think that what we are trying to focus on is sarcoidosis patients. There is a discrepancy between what patients and doctors feel as most important. So patients, they consider that quality of life and functionality is the most important treatment outcome, and this has been captured in a number of surveys. On the other hand, doctors focus more on blood tests, lung function tests, and other physiological outcome measures. So the first important step in bringing closer these two parts, which is primarily for the benefit of the patients, is to we need more information about what sarcoidosis is, what is the risk of its patient, and as mentioned before, follow a shared treatment decision-making by identifying patient needs and preferences. The multidisciplinary management is key because involving more than one specialist for the management of the patient will give a broader understanding of the condition and improves their outcome. I think it's very important for all patients to remember that there are sarcoidosis expert centers where they could get a better level of care, and all sarcoidosis patients should be directed to sarcoidosis specialist centers for that. This is a published, I'm sorry, it's a bit blurred, but this is a published table from the Dutch group that is showing an ABCDE of sarcoidosis care, which I think is quite important, and I would strongly agree with that. So it's very important to assess the extent and which organs are involved, understand what is the symptom burden, as well as what is the patient's needs and preferences. It is important to understand if the patients are on treatment, whether they are getting side effects, but include their caregivers in that decision-making because they suffer too. The second step, which is important, is to provide patients with a lot of information, try to educate, and this is why webinars like these take place. I know that there's also attempts to set up supporting groups, and Sarcoidosis UK has done a lot of work on that to provide patients further ability to come closer. The psychological support and pulmonary rehabilitation seems to be important in backing up the patients. Now, when we look into their symptoms, we have to understand how it is best to address the symptoms and try to provide relief, which is not, we have to be honest up front. This is not always going to be effective. And we do have the disease-modifying treatment options, but then you will see some of the non-pharmacological approaches that have been approved. Now, involving people like cardiologists, immunologists, rheumatologists, neurologists, psychologists, psychiatrists, physiotherapists, specialist nurses, or even at times palliative care specialists is very important when trying to provide the patients with a holistic approach. Now, coming back to the extent of the organ involvement, this is a table that I think represents everyone. As you know, if someone has sarcoidosis, every single part of their body can be affected. And as you can see here, there could be a variety of symptoms that may be covered in this table or even not, that they could have an effect in each individual patient. Here is a very interesting table where you can see that how many patients have been identified to have an organ involvement and how many of those needed treatment. And as you can see, many patients could have lung disease, but almost half of them are treated. Similarly, a significant lower number of patients will have eye involvement, but it seems that they are more frequently treated. If a patient has heart or neurological disease, you can see that the frequency is very small, but the amount of treatment that they are receiving is much higher than any other organ involvement. Now, coming back to the non-pharmacological interventions, and I do think that education is a non-pharmacological intervention. We need to provide as much as possible education to our patients. Unfortunately, the complexity and the heterogeneity of the sarcoidosis may complicate the communication, and sometimes it is very difficult to for patients to either understand what the doctors are saying or even primary care physicians not being able to understand what sarcoidosis is and how it is best to manage. This is part of why Sarcoidosis UK has moved into trying to raise awareness among the primary care physicians, and I'm hugely supportive of that. It's also important to raise awareness among the society or even the employers to understand better why their patients cannot really function on the day-to-day work. The supporting groups seem to have beneficial effects on quality of life, and this is another type of intervention that we could consider. Coming back to the self-management, overall, in all the chronic conditions, developing self-managing support seems to be one of the main pillars of the chronic care model, and this needs to be adopted in sarcoidosis patients. These would include domains such as behavioral changes, lifestyle changes, medication use, exercise, diet, or even home monitoring. I think that now with the changes following COVID, there is a significant move to e-health solutions, and we will see as things move on that a lot of the, in many cases, we will try to self-monitor quality of life, activity, or even pulmonary function tests at home. I think that coming down to exercise, I think exercise should be considered one of the most important non-pharmacological interventions. And we know that pulmonary involvement, fatigue, and reduced exercise tolerance are the main indications for physical therapy in sarcoidosis. Now, the current evidence suggests that the structured supervised exercise program is definitely the one that will provide symptom improvement in their symptoms, quality of life, as well as muscle strength and exercise capacity. And this can happen in different stages of sarcoidosis. It should be irrelevant to the disease extent. Now, although the supervised programs and the modern multidisciplinary pulmonary rehabilitation are gold standard, you can still move on with activity tracking at home, and especially using the iWatches now, I think is very important to, I would encourage you to do that. In surveys among sarcoidosis experts, they actually consider that rehabilitation and physical training is the standard of care for every single sarcoid patient. So this needs to be taken into account. Now, psychological support is very important, and the majority of the patients would like to have better access to psychological support, and I understand that it does become a taboo at times to discuss this. And in clinical practice, we tend to refer patients to a psychologist or a psychiatrist for further counseling and treatment only if this is indicated. However, I think that CBT is a promising method to provide patients coping strategies as well as ways of trying to reduce their stress and anxiety, which is important. And this should apply to every patient, I believe. Now, just a few examples about how can we deal with non-pharmacological interventions focusing on symptom relief. For example, breathlessness is something which is multifactorial. It could be related to the lungs, to the heart, to the muscles, to the joints, or even to just the conditioning and lack of fitness. The physical training, the rehabilitation would be helpful with that, but also the cognitive behavioral therapy could have a role in improving the breathlessness. Cough as a different symptom is evident in up to half of the sarcoidosis patients. In this particular group of patients, we will look into other causes like reflux or postnasal drip. And we shouldn't really forget that apart from the inhaled steroids that very frequently are prescribed, speech therapy could be actually a non-pharmacological intervention that makes a difference in this particular group of patients. Now, coming to the most important and the most troublesome symptom, which is fatigue, this is a multifactorial problem. And we have to understand that improving by 10 or 20% is a major achievement. There are number of factors that could contribute to fatigue, such as sleep disturbance, psychological problems, cognitive impairment, reduce muscle strength, or even medications that we are already giving to the patients. Comorbidities such as thyroid dysfunction, iron deficiency, or diabetes can cause fatigue, and adrenal insufficiency has already been mentioned, but it shouldn't be forgotten, especially for patients who are long-term on steroids. Physical training and CBT are beneficial for patients with fatigue, and this needs to be part of their standard of care. I'm just finishing with a table that shows how much non-pharmacological approaches could help in addition to pharmacological therapy, and that's why multidisciplinary approach is quite important in managing patients' symptoms, either organ or non-organ specific. Thank you very much, and I'll try to answer as many questions as I can.
Okay, so that means it's my turn then, yeah?
Yep.
I'd just like to take the opportunity to say thank you for inviting me to come and ask the questions on behalf of the patient. And I'd like to start off with one of my questions, which is, you know, I'm just trying to get a bit of a feel about how you do things and how you are. And so my question will basically be, how do you maintain empathy and sympathy for patients delivering something that is really repetitive? Because obviously you do this day in, day out. How do you remain, you know, how do you have sympathy for your patients and empathy, you know, when delivering bad news to them?
I think it's very difficult, and we have to acknowledge the fact that NHS is under a huge pressure for a number of reasons, especially after the COVID pandemic, but even prior to that. And I think it's down to each consultant's personality, really, to provide that level of support to the patient. I think the way that I approach things, but I think our whole department is in the same mindset, is that we are not actually taking the place of God, or we can actually give you life sentences from a sarcoidosis aspect. We are people who are specialists in the field, try to educate ourselves all the time, and we have more probably knowledge about especially the pharmacological treatment interventions and what they would like to offer. I strongly believe that it is the patients who know, and the patients who have to tolerate treatment, and they know how bad the disease extent is. So they already know how much this is affecting them. If I know more about the risk of a heart arrhythmia or a neurological damage, then obviously I need to share this with them so that they know and understand where I'm coming from when telling them that you need to take more steroids or methotrexate or any other drug. Mm-hmm. But this is a shared model of decision-making that I'm trying to follow, although it is very difficult at times because both me or the patients could be distressed. There could be a huge clinic waiting. Every patient would like to have an hour to discuss their problems, and they are offered 15 or 20 minutes. And this can go on and on. However, I think once things are raised by the patients, we are trying our best to find extra time, even outside the clinic, to discuss the issues that trouble them and try to make a plan that offers them the best management.
Okay. Another one here is basically the patient saying that she recently got diagnosed with heart sarcoidosis in January of this year. And she's been having a lot of episodes, a couple of episodes in a year, but she mistook it for lack of vitamin B12. So she had some courses of vitamin B12 injection and improved it a lot. So her question is it possible that the increase of vitamin B12 can give symptomatic relief by increasing the hemoglobin and improving the oxygen saturation and circulation?
I think it's a good question, and I think I will try to answer this by covering a bit about a question that I saw about dietary advice. Now, as part of the baseline assessment, not only for cardiac sarcoidosis patients, but also for any kind of patient, measuring the hemoglobin and identifying whether the patient is anemic is key. So if a patient is anemic, that is strongly taken into consideration by every sarcoidosis expert, I think. Now, with regards to measuring B12 or other supplements without anemia, I think that this relies on the different individual specialists. I am not aware of a link between B12 and cardiac function or rhythm in the absence of anemia. But in the presence of anemia, obviously everyone is trying to improve as much as possible the anemia and would measure B12. So if a patient is anemic, I would strongly agree that you have to find the cause, and if this is B12 deficiency, you have to treat that. Whether this will change your cardiac function, then that's, I think, is a different thing. And I wouldn't really rely on B12 in improving the cardiac function, just because the changes in the cardiac function can be minimal and result into major events, such as a heart rhythm disturbance that can be life-threatening. Now, in general advice, I'm very happy for the patients to take supplements that are helping them in their well-being. And they could potentially change their diet. They could find ways of improving their lifestyle without, from my personal view, significantly affecting their sarcoidosis control. This is a bit of an unknown territory. We don't really know whether lifestyle changes on their own could result into improvement or control of an inflammatory condition. I personally am not in agreement with anti-inflammatory diet, but I don't mind if a patient follows an anti-inflammatory diet, but at the same time follows the suggestions regarding treatment interventions, either pharmacological or non-pharmacological. So I'm pretty open to the discussion about diet change, but most importantly, I think that when advanced disease such as cardiac disease comes into play, we have to be careful, because a life-threatening event can occur, and this may not be predicted at all times.
Okay. Can reducing sugar in your diet help to reduce inflammation?
Yeah, I think I've tried to answer this. I think that's a good question, in the sense I'm not aware of any association between sugar and sarcoidosis inflammation, apart from the fact that the patient who's on steroids has a higher risk for diabetes, and therefore the sugar intake should be controlled from that point of view.
Okay. And also, is anxiety and depression is it a majority for physicians in treating sarcoidosis, as it can be is responsible for physical symptoms like chest and gut pain? So basically, it's just asking if anxiety causes, is it problematic?
Mm-hmm. I think that all the sarcoidosis experts have clearly stated that anxiety and depression is a major problem in sarcoidosis. There is no doubt about it. We see that this is a problem that may require even pharmacological intervention, but even prior to that, I would prefer if I could offer CBT to all my patients, and I'll try to explain why. Having a diagnosis of a chronic condition that manifests itself in various ways, and after finding out the fact that the treatment options that you have available may not work or may cause you a lot of problems, by default it causes anxiety. So I would like my patients to get access to any form of CBT if possible. Now, whether the anxiety is causing sarcoidosis activity is very difficult to say. However, there are many studies that have shown that anxiety and depression is much higher in a sarcoidosis population compared to the general population. Is this linked with inflammation? Very difficult to say. I think that all patients should consider that as being part of their chronic disease and try to ask for help, especially when this affects their functionality, their ability to work, their ability to live their day-to-day life. I think this is the moment that they have to ask for more help. If we could, we would better offer these patients support, even if this doesn't seem to be their major problem. So from the outset, but that's unfortunately not very easy.
Okay. It says, how can individuals manage their vitamin D and calcium levels? The 125 test is not easily available, and GPs are reluctant to do routine monitoring. How can we monitor this in a safe and an NHS cost-effective way?
I mean, if the GPs are not doing it, there is no NHS cost-effective way. I think although I can see that the patients are getting a lot of information, and they have details about the specific subtypes of vitamin D that are active within our body. My preference is exactly what Dr. Ranzoni said. I think that when we have a patient who is deficient in vitamin D, and we have to measure their bone density. If their bone density is reduced, the patient is on treatment, or even if the patient is not on treatment, but they have low bone density, we have to consider treatment supplementing their vitamin D. It's important to measure the serum calcium and 24-hour urine calcium when doing that, as well as sometimes considering to exclude primary hyperparathyroidism, which could be playing a role. So if you start a patient on vitamin D, you just monitor that this doesn't really cause any side effects. I think that's the safest option. When you reach your vitamin D levels being sufficient, then you can discuss about discontinuing therapy. I think, although vitamin D has been associated with a lot of benefits in the general population, the only message from us is that you just need to be careful about taking supplements.
Sorry, I'm not too familiar with the 125 test. What's that about? Do you?
It's a subtype of vitamin D that is considered to be the more active form of vitamin D in our body.
Okay. Also, it says, can changing living environment be beneficial for sarcoid? So, for instance, moving to a hotter country.
I think that, and other colleagues would comment on that, but I think overall, warmer environments for patients with advanced pulmonary disease, they feel as if this is better for them. So, but I have seen this primarily now. I come from a very warm country in Greece, and I can tell you that the severity of sarcoidosis is not really different compared to the severity in the UK. Now, if a UK resident goes and have some holidays in a warmer environment, they report that they feel better. And that may be the case, but I'm not sure that their condition really changes. Now, I'm not sure whether someone who lives in a warmer environment feels the same when moving to a colder environment. So I think that this is something that has been reported by patients, that warmer environments feel better for them, but I'm not sure that this is an advice that we should provide them, because their underlying disease is not different. Yeah, so it's more of a symptom.
Yeah, but if you're mentally, if sarcoid is related to depression and anxiety, and if you move to a warmer country, you feel better and you're mentally better, somehow should that not affect how you feel and how your body feels, because mentally you're where you need to be?
No, I agree with you. I mean, it's a very difficult balance, because let's say, for example, I would like to be on holidays every single moment, but I cannot. So I mean, it's a balance between what you would like and what you can do. Obviously, if whatever, as I said earlier, whatever makes someone feel better, we should try to get that as much as possible.
Okay. I can see we're running a bit out of time. I might not be able to ask all the questions, but a patient's asking, is cannabis oil a good treat, or have you researched whether cannabis oil can help somebody with sarcoidosis?
So I don't think that it is recommended at this moment in time to have cannabis oil. I know that in the States, this has been used much wider in terms of control of pain, of chronic pain. Now, when discussing this with Dr. Sinkari, our neurologist, as to whether some of the neuropathic pain, the small fiber neuropathy or the neuropathic pain patients that we see, whether cannabis could be helpful, I think there isn't any medication that can be prescribed at this moment in time. We have seen patients using and telling us that they are using CBD, and that has been a life changer for them. So I would say that I don't have data to support one or the other answers, but I think that there is anecdotal data suggesting some response in a specific group of patients.
Okay. Also, what can be done to help someone with insomnia in sarcoid patients?
I mean, it's the sleep disorder breathing needs to be excluded as a first thing. This is obviously not insomnia as such. We have to review their patients' medications, whether this has an effect in their insomnia. And I think it's down to each patient individually to see how we can improve that. At the Brompton, we tend to ask for the sleep and ventilation team's input as the most experts. And this just gives me an example to say that whenever you are coming into, let's say, difficulty in managing someone and you don't know, it's better that you accept that, you say this to the patient and ask from a specialist opinion to try to see whether they can address their problem. But in the first instance, I would review their medications, understand whether taking, for example, their treatment earlier has any effect, or changing their treatment has any effect. And then I would ask for more specialist opinion.
Okay.
I'll try to answer some of the questions just because I'm happy to move to continue, but in 10 minutes, it would be the cardiac session starting. So if you want to have one more question and we can bring it to a close.
So I think I'll just go for how can you advise someone who's on steroids and they seem to just be getting bigger, putting on a lot of weight? What can they do to combat that? And what type of exercises would also help? And how much of it?
I would ask them to try to focus on their diet. Obviously, the weight gain is associated with their appetite increase. So it's more important to have dietitian's input in that setting. And the second thing is that I would strongly advise to exercise. For me, any form of exercise is acceptable. I don't think that we should be directing patients to one or the other form of exercise, whatever suits them best. They can use what I mentioned previously, activity tracking at home, like they can see how many steps they do. What I think is important about exercise is to be regular, and that makes a difference for all patients. They can be cycling, they can be swimming, whatever makes them feel better. But exercise should be part of their standard of care.
Okay. That's it then. There's quite a lot, but we couldn't cover all of it, obviously. But yeah. Oh, if I could ask you anything, last thing, what would you say you would do differently in your clinical journey? What would you do better? Or yeah, what would you do better?
I would like to have more time to spend with my patients and try to understand them more about the actual burden of the disease in their personal, social life. so that I can see whether there is anything else that I could offer them.
And you can't do that because of the fact that NHS don't give you enough time? Because personally, if you don't have the time, then you will never actually know how we feel about the disease. How are you going to be able to best treat us if you don't have time?
I think we are trying to touch on every single part, and knowing with time we know each other, so it becomes better. But if I could do something more, I would like to spend more time with my patients. That's what I think is my struggle.
Okay, thank you very much.
You're welcome. So I would say that we have a short break, and we meet again at 12:10.